My name is Lars Lund. I work at the hospital in the Department of Cardiology and at the university in the Department of Medicine and in the unit of cardiology. And I work on heart failure. And I thought that I would do a very broad overview and try to touch on some of the aspects that you might encounter in your schooling and or research from very different perspectives. So I chose to call it From Molecule to Society because it's a very broad spectrum. There's lots of research in the field of heart failure in molecular biology and genetics all the way until social medicine and economics and implementation. Now, who are you? So there's about, I'm guessing, 30 people, something-ish here, and you are students mostly? In what fields? So who's a medical student? And are you guys in clinical or preclinical? Preclinical. Clinical, yeah. And then nursing student? And then BMA student? And then are you undergraduate students or PhD students in the basic sciences also? Any PhD students? And then in basic sciences? Anybody in epidemiology or biostatistics? Okay, so there's a broad range, right? Good. Okay, so let's hope that this is helpful or inspiring for all of you in one way or another. So cardiovascular medicine, and I think I'm going to until about 12:45. I think, right? Yeah. And the sandwiches were very good. So cardiovascular medicine. So cardiovascular medicine is the central aspect of medicine and healthcare in society. It's overwhelmingly the most common cause of disability, hospitalization, death. And within cardiovascular medicine, heart failure is the common denominator, right? So on the left, atherosclerosis ischemia. This is coronary artery disease, so myocardial infarction and angina, which is caused by atherosclerosis, which also affects the limbs, so peripheral artery disease or the cerebral vasculature causing stroke. Arrhythmias is also exceedingly common. So atrial fibrillation affects up to 25% of the elderly as an associated. It causes stroke, and you need blood thinners, anticoagulation, etc. And then there are less common diseases affecting the heart, such as congenital heart disease. So nowadays, babies born with heart defects can have surgery and live a long time into adulthood. And valve disease, which are the valves in the heart that are also affected mostly with aging. And it affects a huge proportion of the overall population and even more among the elderly. Heart failure in general is more deadly than cancer in general, although of course cancer is much broader in its range. There's some very severe, very lethal cancer and some very mild cancer that can be treated quite well. It's the most common cause of hospitalization of all causes. And the costs to society will increase enormously. And this is very important, and increase enormously, mostly because of the aging of the population, but also because patients with heart failure live much longer now and do much better. So no matter where you are in the spectrum of research or in the spectrum of clinical care, heart failure will be relevant for you in one way or another. So let's look a little bit about molecule to society by looking at a patient. So if we have a patient that we see commonly over in the hospital, a 72-year-old woman who comes to the hospital with dyspnea and edema, and this is a simplification of the first patient I ever had actually as a medical student, which I still remember today and which was very formative for both my research and clinical career. So very common. She has high blood pressure, diabetes, atrial fibrillation, she's overweight, and she has rheumatoid arthritis. And now she's had 2 weeks of increasing dyspnea. She can only walk about 10 meters before she has to stop because she's so short of breath. And she's gained 5 kilos approximately over the last 2 weeks. And then when we see her in the emergency room, she has a blood pressure of 150/90. Is that normal? What's a normal blood pressure? 120/80. Yeah, right. So what's normal, actually, by the way? Normal anything. What's the definition of normal? So a traditional definition of normal is using a population and then looking at the number of standard deviations from the mean. So usually 2 standard deviations from the mean. So when we speak about older patients, normal can be unhealthy. So the normal is not necessarily so useful for us anymore, because a normal blood pressure in untreated old patients is probably a lot higher than 120, but a desired blood pressure in older patients and younger patients is 120. So we're already stretching the boundaries of what we call normal, and this is a big problem or a big challenge for patients. Older patients that are relatively healthy, they don't want to take medications because they think they're healthy and they think they're normal, and essentially they are. But if they do take medications, they can live longer and feel better. So how do we address that with them, for example? So we're stretching the boundaries of normal now. She doesn't have any extra cardiac sounds, but she has rales on the lungs, which represents fluid in the lungs, and edema on the calves up to the knees. So what diagnostic tests might we use here, and what diagnosis does the patient have, and how do we treat this? And it turns out that these questions relate very much to the molecular, human physiology, and clinical manifestations of the disease. So it's a very heart failure is a very appealing syndrome to study because it's very linked to mechanisms, it's very linked to society, and very linked to everything in between. So in terms of diagnostic tests, we might do an ultrasound of the heart and see how it's pumping. And we will establish the diagnosis of heart failure, and then we'll treat the patient mostly with drugs that target heart failure. And we'll look a little bit about that. There are 2 manifestations of heart failure, or 2 important. One is a very severe shortness of breath when the left side of the heart fails and the fluid backs into the lungs. And because of the fluid in the lungs on the chest x-ray, the patient has difficulty breathing. When heart failure progresses more long term, the backup in the lungs causes the right heart to fail. So you know the right pumps to the lungs, and the blood goes on to the left, and the left pumps to the body. And so in that case, there is edema, and this is a catheter in the vein, and the pressure in the vein is high. So the blood pressure, what's the pressure in a vein? So the normal blood pressure in an artery is 120 systolic and 80 diastolic. What's the blood pressure in a vein? What's the blood pressure in a dead person, by the way? Any idea? It's not 0, because the tissues have a hydrostatic pressure. So there's a pressure in the muscles and in the subcutaneous fat and in the viscera. That's about 7 millimeters of mercury. And therefore, the pressure in the vein is about 7 millimeters of mercury. If it were higher, you would get edema. And it is higher in patients with heart failure. It can be all the way up to 30 in the veins. And that's why the patients get edema. In severe heart failure, you not only get backup of the fluids, but you also fail to pump forward. And that means that the kidneys and the organs fail. They don't get enough oxygen. Now, what is the definition of heart failure? Does anybody care to define heart failure? So you're in the clinical. I'm going to pick on you now. How might you define heart failure?
There are different definitions.
Yeah?
I would say it's when either ventricle does not have the ability to pump blood directly
Enough, okay. To meet the body's demands. Right, so a common definition that we use is to say that the heart cannot pump enough to meet the body's demands. For what? For oxygen. And oxygen is needed for metabolism. Because what happens if you don't deliver oxygen? You get anaerobic metabolism. This is what you guys all study, I presume, at one point or another, right? So you get anaerobic metabolism, and in anaerobic metabolism, you generate lactate, which is buffered to acid. So you get acidotic. So it can't be right, because if you don't pump enough blood to meet the body's demands, you get more and more acidosis, and you die. And that happens. That is how patients with heart failure die. They don't pump enough blood to meet the body's demands, so they don't get enough oxygen, and the organs get acidotic and they start to fail. They fail their function. The kidneys start to fail. You can't, and it becomes a vicious circle where you can't excrete toxins, and you die in uremia, which is a buildup of toxins, acidosis, and you eventually become unconscious. So that can't be heart failure, because patients live with heart failure. So the definition of heart failure is what we just said, or rather, adequate cardiac output, but only thanks to a neurohormonal compensation. Do you know what neurohormones are? The nervous system responds to a poor cardiac output by different organs excreting into the circulation hormones or small molecules that stimulate the heart. Can anybody mention such a molecule? It also happens in the fight or flight response, for example. So adrenaline, for example, right? So the body feels, the kidney feels, the vessels feel, the brain feels that there's not enough oxygen being delivered. So the body compensates and restores cardiac output. And patients can live like this for many years. So that's the definition of heart failure. Focus on the bottom part. And what are these different systems? And this is physiology now. This is human physiology. And this is central human physiology to regulating vascular function, cardiac function, kidney function. So it's very central. And very central is the renin, angiotensin, aldosterone system. So we have some kind of damage to the heart, such as a myocardial infarction or long-standing high blood pressure. Some form of injury or stress which affects the heart, and this reduces perfusion, right? And this really, the kidneys feel this immediately, which really causes an increase in renin, which converts angiotensinogen to angiotensin 1. Is this familiar to how many of you? How many of you have studied the renin-angiotensin system, for example? So most of you, but maybe not all of you. So it eventually converts, so angiotensin converting enzyme converts to angiotensin 2, which then does many things. It causes aldosterone release in the heart. It stimulates vessels and vascular contraction, vasoconstriction rather, and it also affects the heart negatively, and it also goes through the brain to stimulate fluid uptake. So what happens is that the vessels contract to distribute blood to the vital organs, and the kidneys retain fluid to restore cardiac output. That's one example. Another example is adrenaline and noradrenaline. So the kidneys feel a reduced tissue perfusion. Adrenaline or epinephrine is released from the kidney, and the central nervous system releases norepinephrine or noradrenaline, and this stimulates the beta-adrenergic receptor. Do you know the beta-adrenergic receptor? This was the Nobel Prize a couple of years ago, Bob Lefkowitz from Duke, where I went to medical school actually, got the Nobel Prize for discovering and characterizing the beta-adrenergic receptor. It's a 7-transmembrane receptor. Is this familiar? So this is preserved in evolution. A 7-transmembrane receptor which is G protein coupled and signals through cyclic AMP and then does a number of post-translational modifications to downstream proteins. So phosphorylation, for example, of ion channels. So this is a very conserved type of receptor, and a very conserved signal sequencing system, and the adrenaline causes an increase in contractility. So the heart is sick, but the compensation restores the activity of the heart. But is this good or bad? Well, so the fight or flight response is helpful in the short term and adaptive through evolution, but it's harmful in the long run for the heart because you get maladaptive molecular remodeling. So this is where molecular biology comes in. So if we take a biopsy, and we do this all the time, we put a catheter through the neck like this, through the jugular vein, down through vena cava superior into the right ventricle, and we take a little piece of, like a 2 millimeter piece of tissue. And then we analyze this piece of tissue in research and in H&E staining in the pathology lab, etc., right? And even if the patient had a myocardial infarction on the left side, let's say on the lateral wall of the left side, this part of the heart will be sick. Even though the disease is here, this part is sick. So in the last 20 years, we've understood that it's not the myocardial infarction that's the problem. The problem is the response. The neurohormonal activation is the problem, and this is harmful in the long run because we observed that patients that had a myocardial infarction 10 years ago did very well for 5 years, and then they started getting worse and worse and worse with their heart failure, and now they can't walk to the bathroom, even though there was no intermittent myocardial infarction. So it's not the initial injury that's the problem, it's the response, the compensation. So in the long run, this is harmful. And when we take a biopsy of the heart, we can study calcium channels, and we can see that stress causes catecholamines, meaning adrenaline and noradrenaline, to bind to the beta receptor, and through the G protein pathway, phosphorylate the calcium channel, and notice that calcium is released from the sarcoplasmic reticulum in the cell, and which then increases contractility. So very central to heart failure, to contractility and heart failure, is this regulation of calcium release. And in heart failure, this is hyperphosphorylated, so there's a leak here. So there's constantly calcium leaking out into the cytoplasm, which you might think increases contractility. But the problem is that this causes extra systoles, so extra arrhythmias, and it causes ventricular arrhythmia and fibrillation. So if you give too much adrenaline, you can cause ventricular fibrillation. And it also causes not enough calcium to be able to be released during the next beat, because this is cyclical, right? Every beat. So there's too much calcium during diastole and too little calcium to release during systole. So this causes reduced contractility and lots of other things in the cardiomyocyte. And we can study this using molecular biology techniques such as Western blotting. We can, for example, direct antibodies to phosphorylated and dephosphorylated calcium channels and detect varying levels. And for example, if you have a patient with heart failure, this is very phosphorylated. If you give a beta blocker, the phosphorylation is reduced and the function is improved. If you give a heart pump, a ventricular assist device that takes over pumping blood, so the heart doesn't get any stimulus anymore because there's no stimulus needed, you can restore function completely to these calcium channels. So we can use something called left ventricular assist devices, heart pumps, to restore function to the heart. So these are some molecular aspects of heart failure, molecular biology and physiology. Now, let's take a leap into the other part of, so we have a big heart failure research group that we conduct mechanistic studies like this, and we conduct clinical trials and clinical registry-based and epidemiological studies. So now we take a big leap, and I ask to you, what are the greatest discoveries in medicine? If we take a step back, what might a great discovery in medicine be? Antibiotics, great. Top 5, I would say. Maybe top 2. What else? Vaccines, terrific, great. Vaccines and antibiotics. I wonder if I recall correctly, I think they are number 1 and 2. No, sanitation is number 1, because this has made tremendous changes or improvements in life in primarily the developing world, with the hygiene hypothesis that germs spread, etc., and cause disease. Antibiotics, number 2. Anesthesia, vaccines, DNA. And number 8, evidence-based medicine. This is not a thing that you can touch. It doesn't have a structure and function like a gene or a protein or a vaccine or a drug. It is just something abstract. What is evidence-based medicine? Can somebody define that? If we develop a drug in the lab and test it in animals and test it in early phase human trials, we have done only about 10% of the development. The big part comes in clinical trials. The big part in terms of organization and cost. And the way to understand evidence-based medicine is to understand the difference between association and causation. The difference between a risk marker and a risk factor. Can somebody name a risk marker? What's a risk marker? Troponin. Do you know what troponin is? In myocardial infarction, troponin is released into the blood. That's a risk marker. High is bad. It's a marker of poor prognosis. But it's not a risk factor. If you give troponin into the blood, you don't hurt anybody. It doesn't cause anything. Likewise, if I study patients, women in menopause who get estrogen or hormone replacement therapy, if I take all those that did and all those that didn't, and I observe that those that did lived longer, and I conclude that estrogen therapy is good. Did I do anything wrong? So if we did this happened. We looked at huge cohorts of women who did not receive hormone replacement therapy in menopause, and huge cohorts of women who did. And those who did lived longer and had fewer myocardial infarctions, and we concluded that hormone replacement therapy is good. Then we did randomized trials. When we randomized patients to receive hormone replacement therapy and placebo, and it turned out that it was harmful. How could that happen? In the first case, the women who took hormone replacement therapy didn't benefit from the hormone replacement therapy. They benefit from a lot of other things. They had higher education, they smoked less, they exercised more, and they also read more newspapers and thought that it was helpful to take hormone replacement therapy. What's that? That's called confounding. That's a marker. So estrogen replacement therapy is a marker of good health, but it doesn't cause good health. In fact, it causes harm. And in order to distinguish association versus causation, we need randomized trials. And we can adjust for smoking and other habits, but we can't. What can we not adjust for? We cannot adjust for things that we don't know about. So in the estrogen studies, we did adjust for exercise, weight, smoking, etc. And it still looked beneficial. But of course, we couldn't adjust for unknown confounders. And both known and unknown confounders will be distributed evenly in a randomized trial. So the randomized trial is the easiest thing in the world to do. You don't have to ask people how old they are or if they smoke or not, because that will all be evenly distributed. You just have to randomize. And lots of randomized trials have been done in field of heart failure. Heart failure has been the field in medicine, all categories of medicine, that have conducted the most randomized trials and provided the greatest evidence base for proven therapy. And one such intervention is beta blockers. You know about beta blockers, Seloken or metoprolol if you're in the clinic. So the beta blockers block the binding of adrenaline to the beta-adrenergic receptor and restore normal function, or at least improves function of this system. Initially, it reduces contractility, but over a period of weeks to months, it restores function of the receptor and thus improves contractility and also prolongs life and improves symptoms. But there was huge resistance to giving beta blockers because it actually inhibits contractility. It's counterintuitive, right? And I remember thinking that about that first patient when the attending doctor, the senior doctor, said, we need to give a beta blocker. And I couldn't understand it because I came fresh off the preclinical training and understanding the receptor system well and the signaling system well. And I said, this will reduce contractility. And he said, you're absolutely right, but it will help her in the long run. And we know this based on randomized controlled trials. So it's very elegant how we link the whole sequence of molecular biology to physiology to clinical trials. Now, let's round off with how we can bring this into society. So we talked about molecular biology. We take a biopsy of the heart and we study calcium signaling in the heart. We talked about clinical trials in which we randomize patients to receive a beta blocker or placebo, and then we study outcomes to make sure that there's no confounding. And then we don't say to the patient, you can smoke if you want, because we tell all patients you shouldn't smoke, but we don't care if they smoke. We don't care what they do because it's randomized, so there won't be any confounders. So very simple, but very important, right? But there are still tons of unmet needs in heart failure. This is heart failure with reduced ejection fraction. Does anybody know what that means? So heart failure has two different types. In this case, the heart is weak and pumps poorly. In this case, the heart actually pumps well but can't fill with blood. It's stiff. This is a new type of heart failure that we haven't understood for many years. And there's actually no evidence-based therapy here yet. We think that the same drugs that work here, beta blockers, ACE inhibitors, spironolactone, we think that they might work here also, but we don't know. So what can we do if we want to study this disease, which is new? This is acute heart failure. So patients who have reduced ejection fraction, they pump poorly. Preserved ejection fraction, they pump well but can't fill. Some time or another develop acute heart failure. That's an event. We won't speak about this anymore at the current time, but these are the three types of syndromes that we deal with. But let's look at this one for now. So let's say that I think that beta blockers that cost about 30 öre per day also work here. But I need to do a trial. I can't just start using because they could be harmful. There are lots of reasons to think they could also be harmful. I think they work, but I don't know. So I need to do a trial. Can I go to a company and say, let's do a trial? But they say, well, I can't sell my beta blocker, the company says, because there are generic beta blockers out there. So I'd rather develop a new drug. And to develop a new drug costs $5 billion. And anyway, I don't know what that would target because I don't know the mechanisms very well. I am involved in several development programs to understand the mechanisms of this syndrome. And I'm open to testing new and expensive drugs. But that will take a long time, and even if the trials are positive, it will be expensive for society to pay about 50 crowns per day for a new drug if it works in that syndrome. 50 crowns per patient per day. And that's still not much. That's still cost effective, but it's a lot more than 30 öre. So that's the problem. How do we test new therapy? Randomized controlled trials, they provide randomized evidence, the only type of evidence that we can use, but they have tons of limitations. They're complex. We have lots of monitoring requirements, paperwork, documentation, enormous amounts of ethics approvals, really complex consent forms. When I see a patient, which I do every day, and ask them, do you want to be in this trial? They have to read 10, 15 pages of legal documentation saying you have these rights and this is the risk and this and this and this. And that scares many patients, of course, and it takes a ton of time, etc. But we still have to do that because research is voluntary and needs to be fully informed. So there are tons of limitations with randomized trials. And we also use registries when we conduct research. And Sweden has terrific registries like the Swedish Heart Failure Registry or SwedeHeart, which is the myocardial infarction registry. We're very good about this. And in the registries, we can learn a ton. We can see that, oh, women don't get good therapy. That's very helpful to know, so we can direct efforts to make sure that women get better therapy. But it doesn't tell us anything about efficacy. So it has all these advantages, but it's not randomized evidence. We've tried, we've looked in the registry to see if beta blockers help those patients, and they do. But we don't know if it's the beta blockers or something else. It could have been that they all saw doctors that really liked beta blockers and that really read the literature and also treated them better in other ways. It may not have been the beta blockers themselves. So how do we combine this? The registry with the randomization. So we do a registry-based randomized controlled trial, RRCT. And this is also something that you can't touch, but it's almost worthy of a Nobel Prize, and it's a Swedish invention because it uses registries to do randomization. So instead of creating a huge apparatus, a heart failure trial will cost $1 billion to conduct. 10 billion crowns. These are inexpensive but don't provide any evidence. So we do a combination. In the registry, after entering age and sex and making sure that the patients get the right therapy that they should have, we also add a button at the end, include in trial and randomize. And then we randomize in the trial, and all the outcomes are from the registry. So we can do a trial here at 1% of the cost of here. And we can do a trial of an existing inexpensive drug that, if the trial is positive, will cost nothing for society to implement. So the trial costs 1% of the conventional RCT, and the drug that we test costs less than 1% of the drugs that are tested in the conventional RCT. So it's an incredibly appealing concept to generate randomized evidence. And it's not something you can touch. So you can see that the spectrum of... I'll round off with this actually. So you can see that the spectrum of research from molecule to clinical trials to registry-based clinical trials is huge. There's lots of opportunity for exciting things in heart failure. Now, let's stand back and say that we did all this. We did all this enormously complex and advanced and successful research and tested and delivered drugs for patients and for society to implement. Now, do you think that we do that as a society? No, we don't. So we don't use all this evidence. So maybe the biggest problem is what's called implementation. Even if we have positive trials, we don't use the information. One reason is, and this is a big problem in Sweden, is that we have very low standards for knowledge on healthcare professionals. It's totally acceptable for a doctor at some hospital in Stockholm not to know about the latest therapy in heart failure. And as a result, patients don't get the latest therapy in heart failure. It's very demanding to be a healthcare provider. There's a lot to know. But it's also a great honor, right? It's a very attractive type of job. You deal with science and with people. And so it's demanding but attractive. So now we need to improve this. And if we look at some data to show this, we can look at patients with heart failure that are in the Swedish Heart Failure Registry. The green is outpatients, heart failure registry. Blue is outpatients, not registry. And this is inpatients in the hospital registry and inpatients, not registry. And you can see at 5 years, the survival is 80 or 70, 60, 45, and a little more than 30%. And a huge difference. The difference here is bigger than any drug or any device can ever produce. So it's more important to be in the registry than to take the medications. But why is it important to be in the registry? What is it about the registry? The registry is also not something you can touch. So if we look at the reasons, we can see that patients in the registry, they get much better therapy than those that are not in the registry. So the patients in the registry get the drugs that they're supposed to get. They get evidence-based therapy. And if you're not in the registry, you don't. So that's the reason. But how do we know that's the reason? Because we do Cox regressions. We do statistical methods to adjust. And if we adjust for age, because the patients outside the registry are older. And maybe that's why it looks like it's good to be in the registry. But it wouldn't help to put the older patients in the registry because they're still older. But it turns out that there's a small difference in age, and if we adjust for therapy, this difference disappears. So not only do we know that it's better to be in the registry than not, we also know why. If you're in the registry, you get the right therapy. Because if we adjust for therapy, there's no longer any difference. If we took away all therapy, it wouldn't help to be in the registry. So that's observational data. It's not randomized data, but it's very strongly indicative of why registries is a good way to make sure that we implement existing evidence-based therapy. So within the heart failure field, as an example of any syndrome, any disease really, it's a model for the study of the whole spectrum of molecular biology, physiology, drug trials, and access to healthcare, right? Making sure you get all this good treatment. The clinical presentation, and this is what it's appealing and what I remember from my first patient, the clinical presentation is explained by molecular and physiological changes. So there's a link between the molecule, the physiology, and the patient you see. And targeting these changes improves outcomes. But therapy must be tested in randomized trials. That's a principle of evidence-based medicine. And don't forget, even after all this, we need to make sure that the patients actually receive this evidence-based proven therapy. Thank you. I'll stay for a few minutes if somebody is curious or has any questions.